So good afternoon, everyone. Welcome to our From Mandate to Momentum webinar. My name is Brian Dwyer. I'm the Business Strategy Practice Lead here at Point of Care Partners. Most of you probably know us, but for those who don't, we are a health IT management consulting firm with a very deep focus in clinical data exchange and overall interoperability. And in our work, we know that health plans today are juggling the CMS 0057 compliance, the new prior authorization reduction pledge, and their own strategic goals for interoperability and member experience. But too often, these efforts are treated as separate efforts. And we know in our consulting practice, for example, that kind of much of our work is focused on helping our clients to integrate the efforts into a single enterprise strategy. And so we're here to kind of discuss how to do that, how to connect the dots, turning compliance work into real progress on prior authorization reform and broader business objectives. Our conversation today will focus primarily on prior authorization, but we'll be still keeping an eye on broader interoperability requirements of CMS 0057. With that, I'm going to turn it over to our moderator, Vanessa Candelora, to kick off our content and discussion. Thanks for joining.
Thanks so much. Thanks, Brian. Thanks so much, and welcome, everyone. It's great to see so many familiar names and also many new names. So happy to have you all on, and looks like people are still joining. So you didn't miss much, just the intro. We're getting started here. So hello, I'm Vanessa Candelora. I am the lead of Payer Provider Technology, PP&T, Management and Operations here at Point of Care Partners. And today we're going to explore how the investments that many of you are making for CMS 0057 can really be leveraged to deliver on the industry's prior authorization commitments and advance your strategic interoperability goals. I want to level set that the CMS interoperability and prior authorization final rule, as we commonly refer to as CMS 0057, is much broader than prior auth, as Brian said. And today we're really going to focus on two key areas: how CMS 0057 implementation aligns and overlaps with the work to deliver on the prior auth reform pledge, and practical ways to use mandated APIs to make prior authorization faster and more transparent specifically, and we'll recognize ways for achieving other operational efficiencies along the way, as Brian mentioned. We hope you'll walk away with the recognition that 0057 can be more than compliance, and ways to use those requirements as a springboard for transformation and aligning your investments and really your holistic strategy. So while the bulk of our webinar today is going to be a panel discussion, as promised, we're first going to hear a quick presentation by our point of care partner, payer interoperability expert, Kendra Obrist, to level set for the discussion. So Kendra, please come on screen and introduce yourself to give the level set presentation.
Thanks, Vanessa. Good afternoon, everybody, or I guess good morning for those of you who are not on the East Coast, which is where I am. My name is Kendra Obrist. I'm a senior consultant with Point of Care Partners. Have been with the firm for about 13 years, and spend most of my time consulting with our payer clients, some provider organizations, and the technology vendors that serve both of those. That body of work around payer provider engagement using technology has formed the bulk of my largely 30-odd year career in healthcare technology. And I'm really happy to be here today talking about this great subject. Melissa, if you can advance. So I'm going to take just about somewhere 10-ish minutes of this panel discussion and talk a little bit about things that Point of Care Partners has learned and observed over the course of the last 12 to 18 months as we've worked with some of our clients around 0057 and prior auth in particular. I'll talk about sort of the core elements of being compliant, how the 0057 overlaps and aligns with the prior auth pledge. Go through, some challenges and opportunities that we've uncovered as we've been working through these issues, and then close that with just a quick look at a timeline where we're finding most people to be in their efforts to become compliant. Go ahead to the next slide. So this slide represents, the APIs that are across the top of it will be familiar to anybody who knows anything about 0057. Prior authorization, obviously, provider access, payer-to-payer, and then the modifications and update to the patient access API that are required by 0057. The box below it that's labeled foundational really represents work that needs to be done, both technology work and people process work, in order to support those APIs and some of the other transparency and reporting requirements that are in 0057. So, we've looked at this through the lens of sort of data. What is the master sort of data set that's required to support the APIs and the other reporting requirements, whether that's claims data, USCDI, pharmacy data, and what we'll call sort of prior auth informational or transactional data, the architecture and technology that are required to support that. And then on top of, technology and data, we have people. So people, process, organizational readiness, buy-in to this sort of shift that's happening in healthcare. And then two sort of very specific requirements for the provider access and the payer-to-payer API around member consent and education that are really can be far-reaching into the organization as you look at sort of implementing them across those two APIs. So that's just how we've organized our thinking around the compliance efforts. Thanks, Melissa. So I just went through sort of this content here on the left, sort of the components of the rule, interop, transparency, prior authorization, and the data. And then on the right-hand side, you'll see sort of a summary of the elements of the prior authorization pledge. So again, this is a voluntary commitment. Pretty much every health plan, certainly that we work with and that we've talked to about this, signed on to that pledge. And there is some definitely some alignment and overlap. So over on the 0057 side, you see these bolded and italicized. The prior authorization API obviously aligns to standardizing the prior authorization submissions, as well as transparency as the public reporting that's required as part of 0057. So those are pretty well covered as far as alignment between the rule and the pledge. The other two bullets here, reducing the scope of prior authorizations and expanding real-time responses, they're not misaligned with 0057, but I would say they are additive. And I think, we've experienced most of our clients looking at their prior authorization policies, their UM policy, and as they're going through the process of determining how they're going to codify or digitize their policies, are going through a simplification process and saying, do we really need this? Because there's work to be done on everything that they decide to retain as a UM policy. And then, I think it's very interesting, the expanding real-time responses. I think it's fabulous. It is not required by 0057 that automation happens and that responses happen in real time. I think that the language that's in the pledge is especially interesting. I'm just going to read it because I can never remember exactly what it says, but it says in 2027, at least 80% of electronic prior authorization approvals with all needed documentation will be answered in real time. And I think there's a challenge really to the industry as a whole to determine what that really means. How an approval is answered is kind of up for definition. And what real time means is up for definition. So I think that the spirit of that, that we move towards, less sort of badge oriented processing of authorizations and lean into real time is certainly there. I think the implementation of that will be a very interesting thing for all of us to experience over the course of the next 12 to 18 months. Move on to the next slide there. Awesome. So this slide really goes through some, I would say, overall challenges with 0057. And I'll start with the challenges side. Data management, there's really an unprecedented need and requirement to share a fairly broad set of what I might define as member health data with external entities. So, something that health plans are not really used to doing. So sharing with patients, which they've been doing in some respects with the Patient Access API, but sharing with providers in a digital form, a fairly broad data set, and then sharing with other payers, either future payers or prior payers of their member population, really is placing a challenge to understand what that data is, identify it, determine how you're going to manage it and curate it, and govern it over time. Technical implementation, many of the health plans that we work with are in essence scrapping the work that they did with Patient Access API for CMS 9115, and replacing it with a technology and architectural solution that not only will help them meet 0057, but they feel will carry them into the future. 0057 is unlikely to be the last interop rule that we see. And so really taking their time to build a flexible platform is challenging both organizationally and technically for many of these organizations. Organizational readiness, getting the funding that you need to do really strong and good work here versus checking the box from compliance, managing governance of a group of data that really has not been thought of outside of sort of the operational silos that it lives in, and really addressing the lack of resources that are available in the organizations that are implementing these APIs. The clinical data resource is few and far between compared to the need in the industry today. So many organizations have clinicians that understand clinical data. They have data analysts that understand data. The people who understand both of them are a rare breed. Just 2 quick bullets on the APIs. The payer-to-payer API seems like one of the largest challenge there is around managing member consent, how you're going to address payer connectivity, legal agreements, and the like, dealing with member matching. Many payers have been working on payer-to-payer since it was announced the first time many years ago, and there's a great work group being sponsored by the Sequoia Group around payer-to-payer that is really trying to address some of these open issues. And then Provider Access API, there's this elusively undefined thing called a treatment relationship in the Provider Access API. And health plans are having to determine how they're going to define a treatment relationship between a member and a provider, how they're going to maintain that over time, and how that definition will be able to be used in what is a near real-time inquiry by a provider for information on a member. All of these challenges do have the flip side of real opportunities of improving care and enhancing the member experience, something that we all strive for. There's also some, opportunity for career growth. These are some new technical and business challenges for many health plans, and providing opportunities for many of their staff to learn new skills and improve their careers. And lastly, sort of building industry trust. So there is reciprocal data sharing going on here, and providers are always asking for that. They don't want to just give data, they want to get data in return. And there's an opportunity with provider access and for the real sort of combined workflow with prior authorization. Next slide, Melissa. So prior authorization is challenging enough that it required its own challenges and opportunities slide. And so, I'll go through these quickly. So I think anybody who's working on prior auth in the health plan community or the technology community understands the challenges around digitizing medical policy and clinical guidelines such that they can be used in the first 2 steps, coverage requirements, discovery, and documentation templates and rules of the Da Vinci prior auth IGs. Obtaining the prior authorization, this again is transactional data. So what are the dates, who's the member, what are the services, that they're available in a timely fashion. So this data has largely lived sort of in the UM system, either internally within the health plan or in the delegated UM entities. And now it has to live in such a way that it can be accessed in a very timely fashion under a day in order to be shared by these APIs. And that data has, again, not moved fluidly through the organization in the past, other than between the UM system and the claims system. And it was generally just an auth number, and it happened in batch because the claims didn't certainly come in real time. So I think there's a challenge there from a timeliness perspective. Managing and sharing the related structural and unstructured clinical data. So not only is the transactional data about the auth required to be shared, but any supporting clinical data needs to be shared. And again, that data has lived sometimes in a file cabinet, usually in a document repository somewhere. And it isn't necessarily tagged or organized in such a way that it makes it conducive for sharing. Delegated entities, both for the transactional data that we talked about and understanding sort of routing and orchestration between the three components of the burden reduction. IGs is challenging not only for health plans, but for their delegates. And the last challenge, and there's more than these, but these are the key ones, is around the provider and what are they going to be able to do? What are the EHR vendors providing for them in terms of capabilities? The EHR vendors are pretty disparate in what they're doing here, and sort of understanding what's on the other side of those APIs is really important and I think challenging today anyways, although it's getting clearer day by day. What are the opportunities? Again, we talked about simplifying the policies. There is real opportunity for savings, financial savings here on both sides of the equation, both for the health plan and for the provider audience. And then reducing burden and frustration. This is always sort of one of the top areas of frustration for providers. Members are frustrated when they can't get the services that they want. So not only is there financial benefit, but there's a satisfaction benefit to be gained here also. And so we can move on. So this is, a slide just really about what else is going on in the industry. We've talked about the regulation and sort of challenges, what's going on from a policy perspective. So I think, we were certainly pleased to see HTI-4 and the aligned certification criteria around the Da Vinci IGs, the workflow triggers at the hooks, and subscriptions to support the status of authorizations. Little disappointed that there wasn't a little bit more teeth in the certification criteria, which are always voluntary. But in this case, the criteria are not considered part of sort of base EHR, which sort of ups the stakes on the EHR vendors and other technology vendors need to implement them. And then from an industry perspective, a couple of state level engagements. There's probably more than this. These are some of the ones that we're involved in. The Massachusetts Health Data Consortium, and we have Lauren here on our panel today. They are obviously working in the state of Massachusetts to enable prior auth in a coordinated fashion amongst payers and providers. In the state of Washington, we're working with both payers and providers in a set of work groups that are sponsored by the Healthcare Authority, the Office of the Insurance Commission, and funded by Gates Ventures. And Multicare, the provider organization, many of you know Anna Taylor from Multicare. We're working with a combined group there to try and enable sort of the implementation and the forward progress of prior authorization. I mentioned the Sequoia group, payer-to-payer work group already. And then, of course, wouldn't want to forget Da Vinci and the piloting cohorts that they're working on, always trying to advance the real-world implementation of the Da Vinci IGs. And this is my last sort of slide here. People who have worked with us or seen many of our webinars have probably seen this slide with the different phases of a compliance program, starting with assessing and analyzing where you are, making decisions, and then executing. What we're finding right now is most health plans are in sort of phase 3 of execution. Some are still making decisions. Most have gotten through their assess and analyze, but really are working towards, and this is towards the API requirements in 2027. Obviously, there are a set of reporting and transparency requirements on January 1st, 2026, which you should be, sort of rolling into production with probably here certainly in the fourth quarter, being ready to support those initiatives. But regardless of where you are in here, if you're still just beginning or if you're in execution mode or trying to make some decisions, we're certainly here to help if anybody needs help. I think that's all I have. If ready to turn things over to Vanessa, our moderator.
Thanks, Kendra. That was awesome. Thank you so much for level setting. It was you always excel at presenting information succinctly and efficiently and with deep insight. So I'm sure many folks relate to some of the challenges you outlined and where we are with the policy and regulatory space and the pledge. So thanks so much. If our panelists can join on video now, we'll do a quick introduction for those that haven't yet, and just name, organization, and your title or your relevant role to this panel today. And I'll go in my order. So we'll start with Lauren.
Sure, thank you. I'm Lauren Bedel. I'm an associate director at the Massachusetts Health Data Consortium, or MHDC, and an associate director for business development and data governance.
Excellent. And Lenel James.
Hi, thanks, Vanessa. Lenel James, brand new consultant with Point of Care Partners. Many of you may know me from my 20 years at Blue Cross Blue Shield Association, active in developing many of the standards and accelerators. Happy to be here to share some insights.
Excellent. And Alix Goss.
Hi, I'm Alix Goss. I'm a senior consultant with Point of Care Partners, really bringing today a level of expertise garnered over almost 4 decades of work here, starting out with my Medicare Part B foundational work in operations management, really making the payer environment for fee-for-service work effectively, to my background working with X12, being a federal advisor through a variety of administrations, but probably folks know me most recently as I've been a part of the Da Vinci Project since 2018 and became the program manager in 2024. So I'm really excited to be here today to bring a multi-stakeholder initiative perspective, but also the deep specialty project experience that I have. And thanks for including me.
Excellent. Thank you all. And we've heard from Brian Dwyer and Kendra Obrist already. So we'll dive right into our panel section of this meeting, and then we'll leave some time for questions at the end. So if you do have questions, don't hesitate to enter them into the Q&A feature within Zoom. Thank you. All right, so we seem to be experiencing a bit of a sea change moment in healthcare. What do you think is driving the push to reduce prior authorization burden now, after years of discussion? And how realistic is it for health plans to deliver on this new pledge within the promised timeframes? And we'll start with Alix and then go to Lenel.
Awesome, thank you. Well, prior authorization has been a topic for a lot of years, and we adopted a prior authorization HIPAA standard 25 years ago, and that adoption remains extremely low at 35%, that is a stark contrast to what we've seen through the other transactions, such as claims at 98% or eligibility at 90%, 96% adoption rates. And even claim status has been at 80% adoption rates. The policy discussions nationally, since we had initially adopted HIPAA, but especially since we did a retrospective review in 2015, deeply recognized the challenges with prior authorization and led to some other collaborative efforts through the National Committee on Vital and Health Statistics and ONC's Health Information Technology Advisory Council or Committee. Back in 2020, we produced an intersection of clinical and administrative data report, which I was really honored to co-chair with Cheryl Turney from Alivance. And that may sound like a familiar report. I call it the ICAD in short, and it was cited within the preamble of 0057. But beyond all of that policy, standards, community discussion level, we've heard and seen how fed up patients are. Their cultural aspects, I think, are significantly shifting, and our capabilities that we walk around in our pockets all day long with our phones have added to that cultural expectation shift from our citizens. And so I think the sea change makes a lot of sense. I've seen it coming for a while, and I'm glad it's finally getting here for 2027 to really set the new foundation. And I think it is realistic for health plans to deliver. It's been very clear for a while. I mean, Da Vinci's been working on prior authorization burden reduction IG since 2018. So the landscape shift has been is for me in the rearview mirror to some degree, but it's going to take the commitment of leaders to invest in making this a priority and allocating budgets. And I think that the pledge is really bringing an added layer of visibility and accountability and alignment. It's garnering more champions, fostering more or cross-organizational efforts to lean into proving out the scalability of all of this. So I think that from an enterprise level, to lean into medical policy digitization, addressing the implementation and being a part of the community, as well as supporting their own workforce development and skill sets, is part of the shift that I'm seeing within the industry now. And I think it's feasible, and especially if folks lean in a little harder now that they've got some earlier due dates thanks to the pledges that organizations are making. And Lenel, I'm curious as to what your thoughts are on the sea change.
I've got many, but I'll try to just share just a few. Thanks, Alex. In addition to my role at the association, I spent two-year terms on the board of HL7, so I was involved in the strategic planning and also looking at the AI capabilities for the industry. And I agree with Alex, this deadline is feasible, but I want to separate the challenge from small plans. And those of you who know the association and the association plans, the association has small, medium, and large plans. Medium and large plans, from my perspective, have the staffing, the financial wherewithal, and have usually been involved in HL7 meetings, WEDI meetings, Civitas for Health meetings. So that group understands at the management level what needs to be done. But here's their challenge, and then I'll separately talk about the small plans. Their challenge is, as managers, they understand, they've been to Connectathons, they know what needs to be done. One of the challenges is getting senior management to appreciate the level of commitment, the level of change, the level of researches. And then in the current political environment with funding changing for Medicaid, there's a financial implication for, I'm going to invest all this money and it's unclear whether when I hit that date, is it still going to happen? So that's, from a senior management perspective, the Indians are ready to go, but is the chief ready to go? So there's a need to make sure senior management understands for real, this is going to happen. Will it hit that date? Well, maybe it may miss it by a little bit, but it's such a long tail to get ready. So that's one part of the challenge. If you go to the smaller firms, I think the biggest challenge is they have historically, over the last 3 to 5 years, have not had the resources to come to the HL7 meetings, to come to the WEDI meetings, and get and build that understanding has been a challenge for those small plans. Now, the good news is there are small vendors that are willing and available to help them, but for the small companies, it's maybe not on their radar as a thing. They really, really can't dodge that bullet, but they may not be aware of all the resources that are there. Last but not least, give the CMS Connectathon that goes every summer. They had 1,500 people. They had to turn away people. So there are resources, there are opportunities like this where you don't have to pay, you can come. So I think it's a matter of making sure the industry, we as the industry, make sure we outreach to all payers and all payers and the vendors that support them, so that they understand all the resources that are available that are free or lower cost, and hopefully keep pushing the message. This is going to happen, whether it gets delayed 6 months, whether it hits on target, it is going to happen. It's just a matter of when and how prepared you are and how well people are aware of resources like this call to educate people on what needs to be done and options to prepare. Hopefully that helps.
That's great, Lenel. Thank you. And thank you, Alex. I think that paints a really great picture. And I'll just add, for anyone less familiar, Connectathon is an opportunity for developers to actually come and test with HL7 experts available as a forum. So lots of opportunities out there to get involved and really advance your own products with these standards that are available. And Lenel, excellent point on the getting leadership aligned. We see that a lot. So really, really great sentiment. And Alix, thanks for the history there. All right, moving on. So let's briefly describe how 0057 changes the game for health plans, not just for prior authorization, but overarching interoperability objectives. And we'll start with you, Kendra, and then move to Lauren.
I should have unmuted myself. Thanks, Vanessa. Yeah, so I think, and I mentioned this before, I think, the stakes have really changed on the need to manage, curate, and govern clinical data or member health data within a health plan. I think understanding what they need to do in order to share the data is causing them to think differently about that data as an asset that they can then use really broadly in the organization to support other business goals. And so I think that's a real interoperability change. And then the other one is around bidirectional. So providers, they want data. They want data as much as health plans want data. And so being able to share data with them through the Provider Access API, I think that, does a couple of things. It builds that trust and engagement with the provider community. It also, for those of you that are spend any time sort of working on what you need to do to support the NCQA transition to electronic clinical data systems, one of the provisions of that is any data that is used in order to support your HEDIS reporting that was acquired from electronic clinical data systems needs to be made available to the care team. Well, how are you going to do that? The Provider Access API gives you a tool that gives you the opportunity to share that data. They still have to ask for it, and that's perfectly fine. But it checks that box in a way that really has been unable to be checked before. So if you get data from the providers and you put this mechanism in place with provider access to share it back, you've met that requirement automatically.
Yeah, I think that was really well said. I would add, CMS 0057 is really forcing us to shift from document-based exchange to this, resource-based ability to capture, high quality and high fidelity data. And so if we, focus our efforts on coordination with our provider trading partners, this is really an opportunity to truly alleviate a lot of that burden of finding out the requirements, finding the data, standardizing or mapping it, and actually exchanging it. And so, by focusing on those efforts and kind of co-designing that workflow together across these many different transactions, we can avoid potentially reverting to what we're doing now, which is not streamlined and, really isn't providing members, access to their own data in real time. And giving them the authority over how their data is shared between their payers and providers and ultimately really benefiting their experience.
Great real world insights, Lauren. Thank you so much. Excellent. All right. So why is it so critical for health plans to view this compliance and the prior auth reduction pledge and their own business goals as interconnected rather than separate tracks? And how can plans reuse and repurpose some of that work? And Kendra, you touched on this a little bit with the quality work and sort of, getting the data once and using it for multiple purposes. But feel free to expand upon that, and then we'll go to you and then to Brian Dwyer.
Yeah, so I think that's a good illustration of that. The business units within a health plan, and there's a lot of them, have always operated somewhat independently. They have needs and business goals, and they go out and they do things in order to achieve those goals. They partner with vendors, they acquire data, they have people, and each of those have been done traditionally in a silo. And now, there's a need for that data to come together to support the APIs. And when the data comes together, the business processes need to start to come together. And if you do them in isolation, I've seen this. I've seen in our health plan customers where they've hired two different vendors to essentially do the same thing because the two sort of parts of the house weren't talking to each other. Or they have data stored in different places that are not compatible in any way to be combined whether it be literally or figuratively. And so not only are you seeing duplicative efforts, but then you're seeing conflicting efforts. And so, to eliminate that and really get the business value out of the work, they need to be thought of in a cohesive way and really think about compliance not as a cost center, but as a value generating center within the organization. Brian.
Oh, I thought it was frozen. I'm so sorry. Yeah, I mean, Kendra and I work together, and so we're seeing the same things, but so well said, Kendra. And to Lenel's point, I think a lot of the work that we're doing now is helping the folks who understand all of this already to kind of communicate it upward in a cogent fashion that gets senior leaders to kind of get the vision and understand the opportunities for the organization, for efficiency and et cetera. So yeah, that's my 2 cents, Vanessa.
Great. Thank you both. It's a lot of data, and there's opportunity to leverage it and get more efficient. And it's great to see a lot of the work that Lauren's doing within MHDC as well around that for their members. Lenel, go ahead.
Yeah, I
Yeah.
just wanted to follow up quickly on a comment that Brian made, which is the importance of a keyword I like to use called alignment. A lot of times what's missing is there's not alignment between what the security guys are thinking about technology, or what the lawyers are thinking about the legal rules, or what provider relations are thinking. But one of the things I like to remind people from a payer perspective, we're still getting faxes. We're still using portals to try to get to the broad audience that any multi-state payer has to get to. And the challenge that I give to all of us is, please try to align these things, because they do align. The technology cuts across multiple sectors, and people underestimate how much they can reuse this fire technology for other things. And as many of you that are technical know, you can take a document that could be CDA or some other standard and can convert it. So you can meet people where they are, and you can find a vendor or a tool to convert it to what the payers in the large states and the government needs. People are thinking, oh, I've got to do this in fire. No, you have to find somebody who can get it to fire for the last mile, but you don't have to re-architect your insides. And I think there's a misunderstanding of how well you can align old tech with new tech. But again, that's why we share this information, so you can hopefully find the resources to make sure that alignment is part of the senior strategy. Thanks.
And if I could just add 2 cents to that, because I think we're really picking up on that data theme from Kendra and Lauren, and that document transformation. We're also talking about not the data is common. What we need is common, but yet enterprises have silos. And one of the presentations I saw at HIMSS this year really resonated for me, from a vendor who said they're going into organizations and they're feeling like a marriage counselor, because they're bringing people together from different sides of the house, and we need to break down those internal organizational walls, because the data is the data. And we need to figure out how to use that in a whole different way and foster that alignment organizationally, as well as across the data efficiencies that we can garner.
I love it. I love the marriage counselor analogy. And there's so many, different aspects to this, which leads really great into our next question, right? We touched on sort of the technical stack and how that can be added to, not just, it's not a rip and replace, right? We're building on what we've been doing for years and years. And so let me ask the next question here to our panelists. What are the most common obstacles that payers are running into? And are they mostly technical, or operational, or culture, or all of the above, or something different? We'll start with Lauren and go to Lenel.
Sure. I want to give it just a really brief background on what we're doing as a state in Massachusetts through MHDC. So we are standing up a FHIR-based network with our partner Z Omega, moving from our New England Healthcare Exchange network for EDI and setting up a FHIR version. We will maintain the two though. And the beauty of our FHIR network is it just takes one point of access for payers and providers to connect. And once, if I'm a payer and I'm connected, I can transact for prior authorization. I can exchange clinical data for quality measures, which is our other use case, with all my provider trading partners who are on the network or those who come onto the network at a later date. So really consolidating that point of access for folks. We're also very focused on community governance. So really bringing our payer and provider communities together for regular touch points to talk about, designing this workflow, because it's one thing to agree on the exchange mechanism, so FHIR-based APIs, but how is that workflow actually going to work? How are we meeting folks where they're at so that this is a useful solution for them? So I would say I think it's all of the above. I think it's technology, it's operational, it's cultural. I think on the technical side, going back to, I think what Kendra presented earlier, I think the biggest challenge has been for providers to assess what they have in terms of solutions and technology and understanding where their gaps are and whether they need to build or buy, or if they can, upgrade what they currently have. I think we're seeing a mix of both. We have some folks who are able to build the API endpoints that they need, but they want to rely on knee and FHIR as the network to, be able to connect to their trading partners. And then we have folks who are like, we need you to do it all. We need you to build it. We need you to maintain it and also be the pipes. So in that sense, we're able to meet folks where they're at with what they need. On the operational side, I think it's, starting to talk through these different workflows because they're not just changing for providers, but also for payers. And pulling on that thread of the marriage counseling, getting folks to talk to each other because it does need to be across IT, operations, revenue cycle. We need to figure out who needs to be part of that planning process, who's going to be providing education and planning this out with enough time to iterate before we're just faced with that January 1st, 2027 deadline. And then on the cultural side, I think, I'm not seeing this as much in Massachusetts, but I think what could be a challenge is bringing the providers along. I think providers can be a little reticent. I think they've been promised a lot of solutions to prior authorization, but we're at a point where we really do need to co-design this workflow and work on this together, and show our commitment to that. Otherwise, again, as I said, I think providers run the risk of kind of reverting to the current way of doing things because they have found a way to ultimately make it work. However, burdensome it is now. So I think it's ensuring that payers are really, bringing providers along and including them as part of their broader interoperability strategy.
Great, Lauren. I'll take a second look at the technical and operational side. Again, I stated it earlier, not only is there alignment, but payers are still getting faxes. Payers and the providers are upset because they're still having to use portals. Yeah, in a world where faxes and portals really exist, you keep hearing all this new great state-of-the-art tech, and so there's a big disconnect. I think one of the things that people are underestimating is the opportunity to get certified. Again, a little minor thing for HL7, which is it used to be there was classes, but now at HL7, you can get certified. So you can verify the skill level of the consultants you bring in by those certifications. So that's one aspect of it, of the challenge. But then the other thing I look at is when we're trying to operationalize, I'm not sure that everybody understands how big the gap is. If you're a small provider and you're still doing faxes and PDFs, that's a big gap. And it's unclear to me that the provider side is being adequately made aware of all the broad training that's available, from webinars like this, from some of the free webinars and things that are available from WEDI and Civitas and HL7, to the certifications, to people like Direct Trust actually will go on site and certify that you've got the appropriate security that you're going to need to make sure this data is appropriately encrypted. And again, that's the challenge of getting to this broad industry to understand these certification options, these opportunities to have audits, these opportunities to get staff or consultants that you know are certified. And last but not least, the opportunity for people to come to a Connect-a-thon and start experiencing the hands-on, to be able to talk to people, see what's happening, hear the future so that they can be prepared. Again, a lot of assets in the industry, but not a lot of full appreciation for where those assets are and how those assets will help them with the technical and operational side through training and certifications that are broadly known within the HL7 family, but that doesn't help if you're new to this or haven't realized this thing's really going to happen and don't realize how unprepared your staff are and don't realize there's resources available to help them and certifications to verify people have the skill set that you need. Hopefully that helps.
Yeah, thanks, Lenel. That's great. And, I'm really glad to hear Lauren and many of our panelists touch on that trust between providers and payers. And I just think it's, really essential, right? We often talk about financial ROI, and Kendra mentioned that as one of the opportunities in the very beginning of this panel. And I just want to open the floor. Are there any other panelists that want to comment on, the importance of building that stronger trust between providers and also improving the member experience in all of this, which we talked about at the beginning? Why do these less tangible benefits matter, and how should plans be thinking about them in their overall strategy? And we'll try to do this one a little quickly because I want to make sure we leave time for Q&A from the audience. But anyone want to comment on that?
I'd love to comment on that because I think it's also at the crux of some of the multi-stakeholder initiative work that we've been doing. And I've really seen a transformation over the years of, there's been a long-standing tension between payers and providers, and that there's also been a lot of confusion even from patients and members within their, the health plans of getting caught up in some of those administrative challenges, and prior authorization is a big part of it. And so we've seen a market shift of proprietary standard dynamics, really being a driving force for technology, software, and capabilities, to now the new models of shifting from volume-based healthcare delivery to value-based care really needs to put that patient more at the center. And if payers and providers are going to be sharing in risk and financial rewards related to the delivery and reimbursement of healthcare and getting better outcomes, trust is a huge part of that. And so building standards together, building solutions that you, like Lauren's talking about, where you connect once to get many, with an ecosystem that's sharing governance and brain power to be efficient and maximizing our resources, that's hard work, and it takes trust, and it takes, it's a little bit harder to build that trust in a virtual world. And I've seen the power of people leaning into how to build that since COVID really happened. But you need the durability in those hard, challenging conversations where I've got one view, someone else has got another view. And how are you going to meet in the middle to make sure it's meeting that patient's needs? So I know you want to keep this one short, so I'll defer to someone else if they'd like to chime in.
I guess I'll just say, I'm a big proponent of self-interest in terms of organizations making decisions. And I think, sometimes thinking about the other components in the health system, so payers, thinking about providers trusting payers, et cetera. It doesn't happen unless constituents see it as a system, like an engine. And you will fail without considering the interests of the other components. And I think people understand that, but I don't know that organizations often act that way. So I think that's a requirement for us to reach that vision, that ultimate vision. Everyone's interest is our interest.
Yeah. Yeah, it's hard to transition a culture to think about it that way. It's an excellent point. That's great. All right. Okay, so it wouldn't be a Point of Care Partners webinar without us talking about multi-stakeholder collaboratives and initiatives. So what role do they play here? You know, the HL7 fire accelerators that were mentioned early on, and Lenel has mentioned state-led efforts, you know, playing a role in driving progress, providing support to member organizations. You know, how are these initiatives helping align the industry, accelerate real world implementation, right? Delivering on that pledge and that promise. And, you know, how would you recommend to our attendees today to think about getting involved or leveraging some of these communities? And Lenel touched on this a little bit, but why don't we start with Alix, and then we'll go to Lauren, and then Lenel, feel free to add any color commentary.
If you're not playing in a multi-stakeholder initiative, whether it's a regional one, state-based one like MHDC, or a national level one like the Da Vinci Project, you're missing out. You are missing out on the opportunity to foster trust, to and knowledge share. Think about the development, operations, and leadership alignment that needs to happen inside payer or provider organizations on where your strategic values are headed in your mission overall, and how that's going to be underpinned by your technology capabilities in this era where we have data that's going to be harnessed by AI agents and actually extend our workforce capabilities and automate to reduce burden. So if you're not playing in a multi-stakeholder initiative, you are missing out. Your teams are missing out. Your partnership opportunities are missing out. And it kind of goes back to our first question on the sea change that I'm seeing. The movement that has really been happening over the last few decades is that we have to work more effectively as an industry together, and multi-stakeholder initiatives are enabling us to do that. They foster trust, shared governance, distribute the costs, and they underpin the capacity for interoperability objectives to truly be achieved, because we can all debate the nuances of the data and its representation in a standards development sort of multi-stakeholder initiative, or how do we really get the business value from an initiative such as MHDC, where you've got that shared governance, workflow decision making, and moving the needle for the entire community forward. So I'm not sure who else was in the queue, but I could go on for this for a while. Whoever's next.
I'll jump in. I would absolutely echo everything Alix said. I think, you know, from the vantage point of MHDC, you know, operating as this, you know, shared kind of utility and technology for payers and providers, but also, you know, really relying on that community governance piece is really what is going to make this successful. Exactly as Alix said, with sharing lessons learned, you know, some of the challenges and successes folks are, you know, coming upon, and folks have been really open with sharing that with their trading partners, with their fellow organizations. And so, you know, by continuing to operate like this, I think it's really going to make us able to scale and, you know, go beyond Massachusetts. I know we already have folks who have provider partners in New Hampshire and neighboring states, and, you know, we want this to be a benefit to everyone. And so we encourage folks to reach out. You know, even if you're not sure, you're still trying to understand what the best solution is for you, you know, we want you to be a part of these conversations and learn from this, so that when you know, start and move forward, you are kind of making up for that lost time by applying some of these lessons learned. And yeah, shoot me an email at lbedel@mahealthdata.org if you want to know more about Neon Fire.
Fantastic. For the sake of time, I'll try to be brief. I want people to be aware of the area agencies for aging at AAA's. Their national organization is US Aging. I mentioned US Aging because they were in Chicago for their 50th annual meeting. And I mention them because they're everywhere, because old people are everywhere, including me, unfortunately. And they have funding from the feds. They're doing a technology play. They're very aware of HL7 and fire and WEDI and Civitas for health. So I think, and they have funding. So I think that's an area people should be aware of. There's also these community care hubs. Turns out in Chicago has one called Age Options, and they've got technology. They're eager to work with the new Chicago Regional Community Information Exchange. I know that because I'm on their board, and it's very interesting discussions on where they want to go to try to align with payers, align with vendors, align with standards, do pilots. And I say that's great, they're doing it. But again, that's that key word, aligning. How well aligned is that initiative, what the city's doing, with what the state's doing, with what the payers are doing? And I see you smiling, Alex, because it's not aligned. And then they go down this separate path, and they get to the end. They go, "Oh, we should have been talking to you sooner." So I challenge everyone on this call: make sure you know where your AAA is in your state and how many there are, because some states have AAAs in every county, but there's like 10 to 12 big AAAs that do big national contracts. And guess what? They subcontracted the local AAA near you. And the payers and the providers are trying to work with those AAAs. And last but not least, let's not forget social services, which is mostly done by non-HIPAA covered community groups,
Yeah.
which makes the lawyers very nervous that I need to provide social and clinical information electronically to an entity that's not covered under HIPAA. Yet another challenge.
Yeah.
I don't have the answer. I just know it's real, it's problematic, yet it's a fantastic opportunity to align efforts with the aging citizens, to funding from the feds, to initiatives that payers, because the payers have to cover everybody, young, old,
Yeah.
newborns, yet we've got a technology and federal regulations that has its own barriers. But again, we got a bunch of smart people working on it. Just wanted to make sure you guys take advantage of the AAAs and the community care hubs that may be in your region
Yeah.
that you should have a payer role in as
Yeah.
part of that process.
Yeah,
Thanks,
Lenel,
Vanessa.
that's a great point. And those community care hubs, extend beyond HIPAA covered entities, which really does help with adoption overall if we look at the system holistically. So excellent point. But there are gaps, right? And we do have a question to go through in our last couple minutes here. So what are your thoughts on certain gaps with the solution, like SNOMED versus CPT codes, right? Clinical versus billing codes for procedures, lack of payer directory, CQL, et cetera. I believe these are real issues and will hinder adoption and scalability, says this question. So I see a risk of overpromising and under-delivering, which can cause dissatisfaction and fatigue. What would you say to that? We'll start with Alex.
Oh, thank you very much. I'm just jonesing to answer this question.
Yeah.
So this is very much related to, I think somebody's been attending our public focus group calls within the HL7 Da Vinci project on prior authorization. We are talking about these issues. And so the first thing I want to say is, folks, we all know it's not going to be perfect. There are going to be problems, left and right, things we didn't envision. This is why being involved in the community is going to make a difference, because we're going to problem solve together. The other thing that we're doing is the community is already reaching out to each other and figuring out how we can coalesce around supporting our payers, our providers, and our patients with a better level of understanding. So we have to get to the providers a list of what are the questions you should ask your vendor. How do you need to get prepared to modernize your workflow in the way you practice medicine and deliver care? And how does that work with the technology stacks that you've acquired? We need to foster frequently asked questions so that people know where to get help, how to problem solve together, and understand that we do not want to have more moral distress and compassion fatigue and clicking fatigue in the provider community. This is about investing in a future that lets automation really help us move the needle so that people function at their highest, best capacity. And so we do have some challenges, but the community is already leaning in deeply to solve them, and we'll have a new implementation set of guides and guidances to help people, as well as our outputs from cross-industry collaborations.
Excellently said, Alex. Thank you so much. And these communities are an opportunity for people to convene. So bring those gaps and let's solve them together. I love it. We are at time. I want to thank you all for joining. Hopefully you heard a lot of amazing things from our esteemed panelists and walk away with the recognition that 0057 can be more than just compliance and promises, and gained a few ideas for ways that you can drive this transformation within your own organizations in an aligned strategic way. And of course, we're here to help. So reach out to Brian Dwyer if you're interested in gaining any further insights specific to your organization. If there were any other questions that we did not answer, we'll make sure we follow up. And again, the recording and the slides will be emailed to all registrants and posted to our Point of Care Partners website. So thank you all again. And thank you all panelists. We appreciate your time. Take care. Have a great rest of your day.
Thank you.